I'll start recording and take it away.
All right, thanks. Thank you so much for having me, and thank you so much for being here. My name is Asha Sarma, and I'm a pediatric neuroradiologist at Vanderbilt. And the topic of my presentation today is practical imaging of pediatric abusive head trauma. Just so you know a little bit about who I am, this is me with some of my wonderful colleagues at Vanderbilt, and me with my family in New York this March. So the goal of this presentation is to increase the comfort of radiologists in planning and interpreting imaging studies in pediatric patients with abusive head trauma. And the reason I wanted to do this is because when I was in training and also kind of during my early years as a junior faculty, I felt uncomfortable at times with these kinds of cases, primarily because the stakes are so high. If you make a mistake, if you're wrong, you could, your words could make the difference in creating a false positive situation where children are taken away from caregivers. And if you miss something or you undercall, then, a child could be in danger. So I think because the stakes are so high, it's really important for us to feel comfortable, as comfortable as possible when we see these kinds of cases. And so the objectives of this presentation are to review the current guidance for modality selection in the imaging of abusive head trauma. And to understand the characteristics of injuries that we see in abusive head trauma, we're going to focus on scalp injuries and skull fracture, intracranial hemorrhage, and parenchymal injuries. And then we're going to briefly touch upon retinal hemorrhage and spine injury. We'll also look to recognize injury patterns that favor abusive head trauma over accidental head trauma. We're going to focus on subdural collections because those can be very tricky, and they're the most common injury in abusive head trauma. And we're going to briefly review some conditions with subdural collections that can mimic abusive head trauma. And we'd like to emphasize throughout, you'll hear me say this multiple times, no single injury is pathognomonic, and close correlation with the clinical history and work with a multidisciplinary team is essential for coming to the correct diagnoses in these cases. So how big is this problem? At least 1 in 7 children in the US have experienced abuse or neglect in the past year. And nearly a quarter of abusive head trauma cases are fatal. And you can see this is a case with some severe parenchymal injury and the long-term sequelae of that with all of the volume loss. And you can see that lasting neurologic impairment is seen in almost 70% of abusive head trauma survivors. The lifetime cost of care of one patient can exceed $8 million. So it's a big problem. And what is the radiologist's responsibility? Our job is to provide informed, accurate, evidence-based imaging, to recognize that no single injury is pathognomonic for child abuse, and to use correct language to convey certainties and uncertainties. And it's important for us ultimately to know what can we know for sure and what is unknowable, and learn how to express that appropriately. We work with a team, so we work very closely with child abuse pediatricians and other teams. What we say, the language that we use makes a difference. So this is one of the things that brings clinical teams down to our reading rooms the most commonly to go over findings. What the words we use are very important. They play a role in decision support and planning of studies, the medical care of the patients, and it also goes into the forensic record. So the radiology report that we generate is a medical and legal document that can be used in civil and clinical proceedings in the context of child abuse. So Dr. Strauss and colleagues put out an article in 2021 describing ideal radiology reporting in child abuse. And the ideal radiology report, according to them, follows the rules of 5 C's. I find that helpful. It's complete. It's correct. It includes relevant, pertinent negatives. For example, our child abuse pediatricians here, when we interpret skeletal surveys, like us to mention the bone mineralization just as a relevant, pertinent negative on all of the patients. It should be conclusive, although the caveat to that is there are times where it's appropriate to express uncertainty, but that should be expressed clearly as well. Cogent, meaning balanced between conciseness and detail. And clean, so free of abbreviations, shorthand, acronyms, and addenda that can be confusing to people. So next we're going to move on to study selection. So this is the most recent published iteration of the ACR appropriateness criteria, suspected physical abuse for children. I think a new version of that will come out pretty soon. As of now, the emergent non-contrast head CT is the #1 study in suspected abusive head trauma in most settings. So these are, they're performed in patients with neurologic symptoms, apnea, skull or other fractures, injuries suspicious for abuse on physical exam, and in patients where abuse is suspected and the patient is under 1 year of age. So infants are the #1 group of children who are affected by abusive head trauma. They also may be appropriate if there is no neurologic or visceral injury in some situations. There are techniques coming down the line, limited protocol, ultra-fast MRI, and black bone sequences that are under investigation right now. When we do these head CTs, doing 3D reformations of the skull, as you can see here on the right-hand side of my screen, this is key for improved identification and characterization of fractures and mimics, and showing the relationships of fractures with sutures, which we'll see shortly is quite important. So this is an example of a fracture that would be essentially impossible to see on just an axial head CT. It's even kind of hard sometimes to see these kinds of fractures when you're looking through reformatted bone kernel images, but here you can see it nice and clearly and its relationship with the lambdoid suture on this 3D reformation. And if you have a high quality study with 3D reformation like this, then it may allow the exclusion of skull x-rays from the skeletal survey being performed subsequently on the patient. So what is the role of MRI? MRI is important to perform in many cases as it reveals additional injury in up to 25% of cases over an abnormal CT. So non-emergent, non-contrast MRI is performed in patients with abnormal CT or concerning neurologic symptoms. And some authors suggest performing this 3 to 5 days after the suspected injury in order to increase the yield. And it may also add additional information regarding recurrent abuse and also injury dating in certain cases. Some authors say that you can give contrast to have increased detection of internal membranes, for example, in subdural collections, although we don't use gadolinium routinely in our practice. Also, cervical spine imaging has been routine. Cervical spine MRI has been routine for a long time, although there's increasing data supporting performing total spine MRI as additional injuries can be seen in the thoracolumbar injury, even in the absence of cervical spine injury. So these are just some cases that illustrate the added value of MRI. So injuries can be inconspicuous on other modalities. So on this CT, these injuries could be easy to miss if you didn't have this MRI. So here on the DWI, you can see these areas of parenchymal injury with low diffusivity in the bilateral posterior quadrants. And here they're pretty inconspicuous. There are also, so this, everything looks washed out. There's loss of gray-white differentiation, but it's hard to tell everything that's going on. It doesn't give the whole picture. You don't see all of these petechial hemorrhages that this patient had, nor do you see this kind of the detail of the diffuse cortical injury. Here's an example of a CT that was a CT abdomen and pelvis where you could see the spine. Very hard to see this thoracolumbar subdural hemorrhage in the lower spine without MRI. And then it can go the other way as well. So there can be technical issues with CT, especially in patients with immature myelination. So here's a patient who had poor gray-white differentiation. Notice that they don't seem to have a lot of mass effect though, which is kind of reassuring, but it's a little bit hard to tell what's going on in the parenchyma here. But on DWI, you can see that there was no evidence of cytotoxic injury in that patient. So next, it's important to reflect on some injury mechanisms in abusive head trauma in order to understand the patterns that we see. So the primary mechanisms that we see are impulse loading. So that's, in other words, the kind of injury that you get from shaking, and whiplash, which is also associated, and then impact, strangulation, asphyxiation. It's stabbing, I think, is a little bit more rare, but children under 1 especially are very vulnerable to these kinds of injury mechanisms because their bodies are different than more mature patients' bodies. They have a large head to neck ratio, so the head is kind of heavy, and they also have weak neck muscles. They have decreased motor control, and they also have ligamentous laxity, so that they're more prone to getting injuries higher up in the cervical spine and at the craniocervical junction compared to older children who are more likely to get lower cervical spinal injuries from similar mechanisms. Also worth mentioning that short falls are a common explanation that's given. So people will say, the child fell off the bed, or something similar to that. They're a common explanation, but they're actually a rare cause of morbidity and mortality in infants and young children, which we'll address further in subsequent slides. So this is Dr. Caffey, one of the first people who ever mentioned that shaking of infants, even without direct impact, can cause abusive head injury. And he described a classic triad of shaken baby syndrome, which included retinal hemorrhage, subdural hematoma, and encephalopathy. And shaking has also been implicated as a mechanism, an independent injury mechanism in abusive head trauma. This was a study where in admissions from people who were guilty of abusive head trauma, shaking was described as extremely violent, could be repeated, and impact was relatively less common. So impulse loading, basically the idea is that, especially in young, in infants where there's a lot of space in the head, they're generally larger subarachnoid spaces and the brain can be a little bit smaller. It's kind of like this plate of Jell-O where, like, if you accelerate the head forward, it takes a minute for the brain to catch up with that motion, and that can cause some injuries. And the kinds of injuries that can be caused by that are seen here. So here is an example of retinoschisis, so injury to the retina here. You can see this hypointense signal in the posterior globe. Here's an example of subdural collections. And then here's some parenchymal injury. You can see some areas of cytotoxic edema here on DWI sequence. So that's kind of a radiologic triad that you can look for. So some clinical red flags. So it's always extremely important for us as radiologists to go back to the EMR after looking at the images and try to correlate what you see with what's described in the medical record. So some clinical red flags are that there is no history. So the child just presents with apnea, lethargy, nausea, and then there are like disproportionate injuries on the imaging, or an inappropriate history, like I mentioned, like fall off the changing table, and then like a very severe injury on CT would be discrepant. So it's important for us to think about those things. Like I said, short falls less than 5 feet are extremely unlikely to cause significant morbidity and mortality. A non-specific history is common in infants with abusive head trauma, such as vomiting, irritability, lethargy, or facial bruising in a non-ambulatory age group. And then findings that favor abusive head trauma over accidental head trauma include a history of apnea, intracranial hemorrhages, retinal hemorrhages, and then 10-4 or pattern bruising. So 10-4 stands for torso, ears, and neck in a patient 4 years or younger. Any bruising anywhere if the baby's not yet pulling up or taking steps, or evidence that the child has been hit with a certain kind of object, where you can see peculiar bruising, low GCS, and outcomes. So the first kind of group of injuries that we're going to be talking about are scalp injuries and skull fractures. So I have a couple of pull everywhere questions. Sorry, I should have mentioned that at the beginning. Let me just go back so you can see the info for that. So here you can either enter pollev.com/asarma242, or you can text asarma242 to 22333 to join. So for this particular question, I made a slide of it before the pull everywhere slide, because the images were coming across a little small and I wanted you to be able to see them. So which of these fractures fits best with a history of fell off the bed? Is it A, B, C, or D? Okay, and now we'll go to the pull everywhere question. Okay, I don't know how to tell how many people have responded, so I'll just wait 30 seconds. Okay, we've got some for B and some for C. Okay, so we'll Okay, so we've got a little bit more for C now. Okay, good. Okay, so we'll come to that information to answer this question in a few slides, but the correct answer here is C. So you'll see that image again, and you'll see why that's the correct answer. So fracture terminology is really, really important. We want to use the right words to describe what we're seeing. And the more kind of uniform we can be with our language, the more helpful we are, and the more our colleagues know kind of how to use our reports. So the mechanism for skull and scalp injuries is direct impact. And then so you can break down these fractures into the categories. So simple, complex, or comminuted. A pattern, different patterns. So you've got, and here are some examples. So simple has 2 endpoints, complex has 3 endpoints, or sometimes people call these terminal ends. And then comminuted fractures can either be fractures surrounding an island of bone. One of the sides could be a suture with a fracture, or even just a diastatic suture without a fracture. They can be linear, curvilinear, stellate, or diastatic. So the diastatic sutures are widened, or diastatic fractures are widened, and they can be depressed or displaced. And a commonly accepted definition for depression is offset by more than 3 millimeters. So here is that example. This was the correct answer in that quiz. So this is a simple linear fracture. These are the kinds that are most likely to be associated with shortfalls. So when you get into these more complex, so this is a complex fracture with some widening. And you can see it's got 3 terminal ends and it crosses a suture. We'll talk about that again in a second. Here's an example of a fracture with more than 2 terminal ends. It crosses the squamosal suture and it's comminuted. It's got this displaced chunk right there. And here's an example of a depressed fracture with more than 3 millimeters of depression there. This is a special type of fracture that can be mistaken for a depressed fracture. This is an infant-specific fracture called a ping pong fracture. And you can tell, you can understand why it's called a ping pong fracture if you've ever seen a dented ping pong ball. But the baby's skull is softer, and so it's kind of like a buckle fracture where it just gets indented. And the mechanism for this is either this happens during birth, or if the child falls onto a toy or something. Like I remember one case I heard of where the child fell on a toy truck, and at the site visit, like that all correlated with the shape of the fracture. So interestingly, these are often not associated with swelling, and if the history fits, there's a low association with abusive head trauma. So don't mistake that for a depressed fracture. There are a lot of troublesome cases. Sometimes like these things cause so many problems that we can't, we have to end up expressing uncertainty in our radiology reports over them, but there are some ways to troubleshoot. So some of the mimics that you can see are vascular grooves. So here's an example. There are just all these kind of veins and arteries that run along the scalp, and they're emissary veins and things like that. So here's a relatively well corticated channel, and you can see that the inner and outer table kind of dip in around this normal variant, so vascular grooves. And then accessory or Wormian bones. So these are just things that you kind of get to know through experience and time. This is an example of what sometimes people call an interparietal or Inca bone. And here are some common accessory sutures. But I find that there are some papers that I go to over and over when I'm wondering if something could be an accessory suture. For example, this nice radiographics article. Here's another one that helps us, skull fracture versus accessory sutures. What are some of the helpful features? So they're helpful, but not foolproof. They don't work in every case, but as these are things that favor a suture. So a zigzag pattern with sclerotic borders, no associated diastasis. They merge with the adjacent suture. They're often bilateral and fairly symmetric, and there's no associated soft tissue swelling, but these ones can be a little bit troublesome. You can see this was actually an interesting case that we saw where this patient has what we thought was an accessory suture here on the right, and there was something symmetrically opposite to that. And you can see here how that looked on the CT because of there was kind of this overlapping appearance that you could see a little bit further down, and it looked so sharp. We favored that this represented a fracture, even though there was something somewhat similar looking on the other side. So in some cases, you either have to give a differential or express uncertainty because you can't always be sure. So skull fractures under the age of 2 Abusive head trauma is more common than accidental head trauma. Again, has to be correlated with the mechanism that's given. And so we see this scenario all the time in both abusive and accidental head trauma. So here is a simple linear parietal bone fracture. There is overlying scalp hematoma, and there's subdural hemorrhage along the inner table here. The simple fractures are the most common type in both abusive and accidental head trauma, but the ones that should raise red flags and concern are multiple, complex, diastatic ones. We mentioned all of those, 2+ sutural contacts. So they touch more than one suture. They can cross sutures and lead to sutural widening. Occipital bone fractures, like in this case where there was an occipital bone fracture with a discrepant history. The patient had a short fall out of a bouncy seat, which didn't quite make sense. And these kinds of fractures are less common with mild trauma, such as short falls. So correlation with the history and additional injuries is vital. So I just wanted to quickly highlight, this is a student, Dr. Spencer Chris, who's one of our medical students who has published a couple of papers showing some of these additional features. So diastatic fractures with 3 terminal ends, and fractures that are contacting more than one suture or crossing sutures can be associated with higher energy mechanisms, such as those seen in abusive head trauma without appropriate clinical history. Another pitfall, swelling and fractures may occur at sites other than the site of impact due to the biomechanical properties of the infant skull. So this is a classic scenario where you have biparietal skull fractures and a history is given of a single impact, but it really can fit. So if you see simple linear fractures, they can the force can propagate down the sagittal suture and go over to the other parietal bone. So that is something that we see. So it's not necessarily due to multiple impacts. Dating skull fractures is not something that we should be doing routinely. It's complicated. It can require multimodal and serial imaging, which is only performed in selected cases. It's a less predictable healing process than long bone fracture. Here's an example of like one of the few fractures I've ever seen where we attempted to date it. So here was an occipital bone fracture, and you can see here on the head CT that there was a little bit of hyperostosis, so it was kind of an attempt to heal. So you could know that this didn't correlate with this history of something that had happened the same day to this patient. And on further evaluation, this patient had multiple classic metaphyseal lesions on their skeletal survey. Another pitfall, so scalp hematoma is variable, so you shouldn't hang your hat on that. It's less common in abusive head trauma than it is in accidental trauma, actually. Here was an example of a fracture that was initially thought to be potentially chronic because there was no scalp hematoma overlying it. But actually, just even a few hours later, this patient came for a skeletal survey and a hematoma had developed, and it can take up to days for these to develop. And then in some cases, they don't develop at all. So scalp hematoma isn't necessarily helpful for dating fractures. Sutural widening by itself without a fracture is a non-specific finding. It can be seen in normal patients with trauma, in metabolic disease, or in cases with increased intracranial pressure. So next we're moving to intracranial hemorrhage. So we have another poll everywhere question. This was a 3-month-old patient with a short fall. So we're looking at the right-sided findings in this patient. So what is the best diagnosis for the finding on the right? Is it A, acute on chronic subdural hematoma, B, subdural collection with bridging vein injury, C, subarachnoid effusion with subarachnoid hemorrhage, or D, subarachnoid space with a normal bridging vein? So we've got subdural collection with bridging vein injury. Let's see if there are any other takers. Okay. Acute on chronic subdural hematoma. Any others? Okay. Well, the correct answer is subdural collection with a bridging vein injury, and we'll talk about this in a minute. So this is a subdural collection. It's got a tadpole sign here that you can see. You can also see that there was a contralateral subdural collection. So good job on not taking the bait and calling it acute on chronic, because that's something we see a lot and that can be problematic. So different extraaxial hemorrhages, you can see any variety of them that you can see in accidental or abusive head trauma. Epidural hemorrhages are more common in accidental head trauma. Subdural hemorrhages are equally common in accidental and abusive head trauma, but they're the #1 injury in abusive head trauma. And subarachnoid hemorrhages, like you can see here, are more common than epidural hemorrhages, but they're more common in abusive head trauma. But more importantly, I wanted to focus on subdural collections and abusive head trauma. So the mechanism for these is impulse loading, and that's more important. They may or may not have direct impact. Concerning signs for these leading to a diagnosis of abusive rather than accidental head trauma or lack of an appropriate trauma history given. So for example, if the patient was in a high-speed motor vehicle collision or something like that, that could explain similar findings, but without that history. Additional suspicious injuries, an interhemispheric fissure or posterior fossa location. And then if they're thin, diffuse, unilateral, asymmetric, and with little mass effect. CT and MRI play complementary roles in assessing these collections. MRI can be more sensitive for tiny or iso-attenuating subdural hemorrhages, especially with flare or gradient echo sequences. On CT, when we do dual energy, the bone removal images can be quite helpful for seeing tiny subdurals adjacent to the inner table. And MRI can sometimes provide detail that is relevant to dating, as we'll discuss. But generally avoid the temptation to date subdural hemorrhages in abusive head trauma, because this can be really problematic because there's a lot of uncertainty in most cases. And the terminology has forensic significance. For example, it can implicate a certain caregiver if you say that if you imply that the collection was a certain amount of time old. It can be problematic in cases with recurrent abuse. And also it's important to remember that what we learn about in intraparenchymal hemorrhages, sometimes the mnemonic like itty bitty baby doo-doo, the subdural hemorrhages don't follow the same time course, because in the subdural space, there's less thromboplastin and oxygen tension, so they evolve differently and less predictably. So subdural collections, hematoma, just some terminology, contains blood. A hematohygroma contains blood and CSF or CSF-like fluid. And a hygroma is CSF or CSF-like fluid without visible blood products. So you'll hear me using these terms in the subsequent slides. So I love this article. I give this article to everybody who will read it. It's called Understanding Subdural Collections in Pediatric Abusive Head Trauma, and it's a really excellent summary, I think, of the most important points of this discussion. So basically the punchline of this is that there are only really 2 scenarios where you could provide confident dating if you had to. So a homogeneous hyperdense subdural collection, or if you're analogizing to MR, it would be a uniformly T2 hypointense collection, is an acute collection that is resulted from something that's happened within the last 1 to 3 days. The other scenario where you could provide more confident dating is if you see membranes. So see on this MR, this T2 hypointense line within this subdural collection, these membranes, sometimes you see hematocrit levels in there. And then you're talking about something that's taken time for inflammation to occur in organization, and that takes longer than 2 weeks. But these other scenarios that people often try to apply dating language to are uncertain. So hematohygroma, so those are mix of blood and CSF or CSF-like fluid. You can either get this kind of heterogeneous or layering appearance. So you can see this T2 hypointense hemorrhage layering back here and more CSF isointense fluid supernatant here, or you can have a more homogeneous appearance where it's kind of the same throughout. But these can represent mixing of blood with CSF from arachnoid tearing, which can even be acute. So these, I would not attempt to date these. Same with these. So I sometimes have seen these called chronic subdurals, which I think is something that we're used to saying more in adult patients, but in this setting, So these ones are, for all intents and purposes, are completely equal to CSF, but they've, in this scenario, could be acute just from arachnoid tearing without significant hemorrhage. So this is just kind of a summary of some nice diagrams that they have in that article. So you can confidently date those homogeneous subdurals with hyperdense appearance on CT or hypointense T2 signal on MR within the last 1 to 3 days. The chronic ones with low accumulation and membranes, which may be enhancing if you were to give GAD, those are chronic. But these hematohygromas, which are homogeneous, I'm not going to go through all of these now, but there you can see that there are 5 different scenarios that they give that could produce this appearance. So dating is uncertain. Same with these heterogeneous ones, 4 different scenarios that they give. The dating is uncertain. So if you remember nothing else of what I'm saying, I think an important point of this presentation is do not routinely date these subdural collections. Instead, I prefer to give a detailed description and use neutral language describing the way that they look, for example, hyperattenuating or mixed attenuation, rather than dating them in the radiology report. And then also another important point is that if you have a mixed density collection or different signal intensities or attenuations in different locations, don't use the term acute on chronic. That can be really problematic. Dating is sometimes important for forensic purposes, but I would do that on a case-by-case basis. And usually I only would do that if asked directly by the child abuse pediatricians. You can provide these estimates in selected cases upon request. And in some cases, they may even request serial imaging to evaluate the evolution of blood products. But in my practice, I haven't really seen that very commonly. Post-contrast imaging, rarely used, can help to visualize subtle membranes in chronic subdural hemorrhages. So it's important to mention that not all subdural collections can be explained by trauma. So here are some examples of other conditions with subdural hemorrhage. So these are birth-related hemorrhages. These are small volume, they're posteriorly distributed. And if you read neonatal imaging, you'll see these, you'll notice that like many patients, like the vast majority of patients within the first few weeks of life will have these characteristic types of subdural collections. Also, you shouldn't probably see these after like 1-ish months. And then this was an example of a case with neonatal vitamin K deficiency. And you can see this patient had come in with this catastrophic hemorrhage and some parenchymal injury. So coagulopathies are another potential reason. So the patient might need more medical workup to exclude those kinds of scenarios. The other condition, so this is a patient who has prominent subarachnoid spaces. So this is a scenario that comes up all the time. You can see that there's a lot of space here. So it would be really easy for this patient to have like a minor trauma and get some arachnoid tearing and develop a subdural collection or even a subdural hemorrhage. You can imagine that. But ultimately, we shouldn't conclude without further workup that these subdural collections are expected. Here was a patient in whom the patient was developmentally normal and presented with macrocrania. They had enlarged subarachnoid spaces and had these membrane-containing subdural collections. But then upon the further workup, there were no additional findings concerning for abuse. So that kind of case could be closed, these small subdurals with an otherwise negative workup and no other findings. But it should prompt a discussion with the pediatrician. So here you can see on the ultrasound that the external arachnoid limiting membrane is displaced by this subdural collection here. You can see the crossing vessels here going up toward the superior sagittal sinus. Here, those vessels are displaced down along the brain surface, and you can see the analogous findings here on the brain MRI, where you can see that those displaced vessels and the subdural collection here. Here's another pitfall. So this is a condition called glutaric aciduria type 1. These patients characteristically have large subarachnoid spaces and open sylvian fissures, and they may have some basal ganglia signal abnormalities from the metabolic disorder. So this condition predisposes patients to subdural collections. This is an example of Menkes kinky hair. So, unusual facies and hair features. Vascular tortuosity, Wormian bones, bone findings, and some predisposition to subdural collections can be seen in that disorder. So these disorders require further clinical workup. This was an interesting case that I saw. So this was a 6-year-old male, and there was a question of abusive head trauma after visiting with his non-custodial parent, who was his father, and there was a minor history of injury while playing football, but nothing to explain a subdural collection. But you can see here, actually, this patient has numerous arachnoid cysts, some of which have hemorrhage in them, and we do see subdural collections complicating arachnoid cysts, even from minor trauma sometimes. Here, moving on to kind of a related point. So bridging vein injury is something that is increasingly well known, but is not known to many. So I just wanted to highlight this entity and its sort of distinctive appearance so that it can be recognized by many people. So here is an example of a normal head ultrasound with Doppler showing this is what these are these cortical veins, and they go through the external arachnoid limiting membrane, and they go across a potential subdural space. So the subdural space doesn't exist unless some fluid goes into it, and then they cross into and empty into the superior sagittal sinus. So there are about 50 of them. They go from the mobile brain through the rigid dura, so they're prone to shearing on that mechanical basis. And they also have less of an endothelial lining, so they injure pretty easily. These are found in greater density in the posterior fossa, temporal, and anterior frontal locations. And then when they're sheared, there's bleeding into the subdural space. So here's just another schematic showing so these are the cortical veins, and they empty into these kind of superficial cortical veins. Here's like a dramatized appearance of the subdural space, which is a potential space. And this is the component that's called the bridging vein. And then those empty into the superior sagittal sinus. And so these can become torn and lead to subdural hemorrhages. So these injuries may be due to impulse loading, injuries like shaking. And I kind of like the term injury because in the literature, there are lots and lots of different terms for these, which I think is one of the things that results in confusion. So sometimes people call them torn bridging veins or thrombosed bridging veins. People have referred to them as parasagittal vertex clots. So there are just all sorts of different terms. I think bridging vein injury is sort of a neutral term. Seeing them doesn't confirm abusive head trauma, but it does confirm that there's been like a high energy mechanism trauma. So we see these in patients who've had motor vehicle accidents or other high energy non-abusive traumas, but there is a high association with abusive head trauma, and it can confirm that the subdural is due to a traumatic mechanism. That's the most important point. These have a distinctive appearance as well. So this is the sign that's been associated with them. It's called either, sometimes people refer to it as a tadpole sign or a lollipop sign. You can see why there's just kind of a little clot and then the injured vein or the thrombosed vein. It's always important to scrutinize along the midline vertex to look for these. On MRI coronal images, including GRE, and even recently published BFFE or heavily T2-weighted steady state sequences can be helpful to identify these. They're commonly missed or misidentified. So these are just some examples that I've seen in real clinical practice. So on this initial head CT, this was reported as benign enlargement of the subarachnoid spaces. On CT. These subdural collections can be really, really tricky. It can be hard to tell if there are enlarged subarachnoid spaces. It can be hard to see those crossing vessels. So this was thought to represent a normal vein crossing the subarachnoid space, which is why it was confused for BESS. You can see there was blooming artifact and tadpole sign on the MRI. Here's an example that was called subarachnoid hemorrhage, and they frequently are. Here was an example where someone thought, because you could see T2 hypointense signal in this subdural collection that was otherwise CSF iso intense, that this was acute on chronic subdural hemorrhage. So we see that quite a bit. And then here is just an example. I just wanted to show one that was in less common locations. So you almost always see them here near the vertex, but here was one that's in the middle cranial fossa. So you can see them in other locations as well. Okay, parenchymal injury. So here's our poll everywhere question. This is a 38-day-old with lethargy. So what is the most likely diagnosis in this case? Is it A, multifocal cystic encephalomalacia, B, parenchymal cysts, C, parenchymal lacerations, or D, diffuse axonal injury. So we've got some for parenchymal lacerations, some for diffuse axonal injury. And again, this is a sophisticated audience, I think, but this can be a tricky thing if you've never seen it before, especially if you're only seeing it on CT. It can be really confusing unless you know what it is. So the answer in this case is parenchymal lacerations, and we'll talk about those in a little bit more detail in a minute. So parenchymal injury is common in abusive head trauma, and it's the #1 predictor overall of the patient's outcome. You can see any pattern of injury that can be identified in accidental head trauma, like contusions or DAI, for example, but we'll focus on some more distinctive patterns that you see in patients under 2 who have abusive head trauma. So this is the pattern of diffuse injury. So diffuse injury, you can see here, there's lots of swelling, sulcal effacement, loss of gray-white differentiation, hypoattenuation of the parenchyma, kind of relative sparing of the thalami here. You can see this in 1/3 of the cases of abusive head trauma, and it's 4 times more common in abusive head trauma than in accidental head trauma. There are multifactorial contributors to the hypoxic ischemic injury that causes this. So some of the causes that have been implicated are apnea. So shaking has been posited to cause injury to the brainstem centers that control respiration, for example. Vascular occlusion, asphyxia, or even seizures could contribute to this. And so because of these complex mechanisms and multifactorial mechanisms, the timing may not follow the same rules as in stroke because the pathophysiology is different. So you may not see the same evolution, for example, on DWI as you would expect with a arterial infarct. The patterns that we see are also strange. They can be really bizarre, non-territorial patterns. So you can see cortical or subcortical injuries, like you can see in these cases. You can see a watershed pattern. You can see a diffuse pattern. You can see a pattern that more exclusively involves the white matter. And it's really common to see it on the ipsilateral side with a small subdural hemorrhage in cases of abusive head trauma. So this is kind of like this is sort of a classic thing. There's a unilateral subdural on this side, and you can see that there's a lot of mass effect on this side, kind of more than you would expect for the size of the subdural. So that's a tip-off that something could be going on in the parenchyma on CT, even if it's not very well appreciated. The details are not well appreciated. So here on the DWI, you can see there was diffuse injury on that side, and probably some axonal injury, Wallerian degeneration type of injury, or seizure pattern involving corpus callosum. And here's the corresponding ADC map. So beware on CT, mass effect disproportionate to the small size of the subdural that can tip you off that you may see more when you do the MRI. So this is another, similar to bridging vein injury. This is kind of a increasingly known injury that maybe a lot of people who've not delved very deeply into this topic may not have heard of, although many in this audience have heard of this before. So this is a focal injury instead of a diffuse injury. This is the parenchymal laceration. Again, the terminology can be really, really confusing because it goes by so many different names. It's also called a contusional tear or a gliding contusion. And these are an injury that's special in infants under 5 months. They're highly associated with abusive head trauma, and they're due to impulse loading or other mechanisms. And they're caused by shearing between the unmyelinated white matter and the gray matter, which have different mechanical density properties. And they're either seen at the gray-white junction or in the parasagittal regions like this. And they can have just fluid in them like this, even when they're acute. So don't mistake them for chronic cystic encephalomalacia necessarily. They may or may not have surrounding edema, so that's hard to date. They can have blood mixed with fluid. Here is an example of ones with blood that are in the parasagittal distribution. Here are some with blood and fluid in the parasagittal, as well as like a more chronic one with some hemosiderin staining here further peripherally in the parenchyma. Retinal hemorrhages, they're highly associated with abusive head trauma, and the fundoscopic characteristics differ from retinal hemorrhages seen in accidental trauma. Retinoschisis is defined as shearing of the retinal layers due to impulse loading. You can see here, it looks like lifting of the retinal layers, like a line instead of a dot, like you see here. They may or may not be visible in MRI. SWI is more sensitive, especially with optimized techniques, but it's still important to look for these. They may be useful in cases if fundoscopy is unavailable or if the patient is deceased before a retinal hemorrhage can be carried out, for example. So finally, spinal injury. So injury to the craniocervical junction is really, really important to know about. An MRI of the spine may show the only evidence of trauma in children who don't have impact abusive head trauma. And like a skeletal survey, documenting of the full scope of the injuries can be valuable even if the injuries are not intervenable. And there is a higher risk for spine injury with severe abusive head trauma. Craniocervical junction injury and spinal subdural favor abusive head trauma over accidental trauma. And retroclival hemorrhage is an important clue. So here's an example of a retroclival hemorrhage, which you can look for on the head CT. The children who have craniocervical junction injuries are at risk for brainstem injury and apnea, which can lead to hypoxic ischemic injury in the context of shaking. And you can see this patient had numerous injuries. There's subnuchal ligament edema, there's facet capsular injury with T2 hyperintense signal here. On the gradient sequence, you can see intraspinal hemorrhage. Here's a hematoma layering. And there's some cord injury in that patient as well, in addition to the brain and retinal injuries, which we saw on a previous slide. Spinal subdural, again, has higher specificity for injury and abusive head trauma. It's interesting, the mechanism for this. So some people think that these myodural bridges are stiff tissue that pulls the dura away from the arachnoid when the patient is being shaken, creating a potential space that allows distribution of subdural hemorrhage from the intracranial compartment. And there also may be a contribution of injury of radicular veins. So it's important to image the whole spine to see thoracolumbar hemorrhages, which, you can see even sometimes when there's not a hemorrhage seen higher up. And also older patients can have isolated TNL fractures more likely than in the younger patients, as we mentioned, in whom the craniocervical junction is more susceptible to injury. So here is just an example. I'm showing some bilateral subdural hemorrhages. Here you can see them on FLAIR. And here in the cervical spine, you don't see the spinal subdural. So if you were only imaging that, you wouldn't be documenting this layering subdural hemorrhage in the thoracolumbar region that you can see here on the T1 MRI, T2 MRI. You can see this dark layering of hemorrhage like here too. And this is a gradient echo sequence showing the same thing. So the largest paper that examined this saw that in 322 children, you could see this in 63% of the cases of abusive head trauma and only 1% of the cases of accidental head trauma. So it's an important finding to look for. So I just want to end with a case. This was just one of the more remarkable cases that I've seen. You can maybe remember this case that I showed you in the previous slide, showing you the parenchymal lacerations. But these findings can surprise you, and you can see numerous findings in this case. This was a 12-week-old who came in with unexplained apnea and bradycardia at a well child check, which is hard to imagine. But you can see this case was puzzling to me because the head looked like it was normal size, but the brain was really small. So I didn't really know what was going on. The cerebellum looked small. I didn't know if it was, rhombencephalosynapsis. Like, it was just hard to tell what exactly was going on here. And then there was some hemorrhage. So the initial differential was abusive head trauma, perinatal injury, third trimester congenital HSV, which can be very destructive, or even some kind of congenital anomaly. And remarkably, this patient had a normal birth history and a normal third trimester fetal MRI, so you could tell that something had happened in that time frame. So here on the FLAIR, you can see these huge subdural collections with layering, hemorrhage, and then these are the parenchymal lacerations, which I showed you on a previous slide. There's a thrombosed or torn bridging vein, there are injured bridging veins. And then they're layering, chronic appearing, and I call them chronic only because you can see membranes in them, subdural collections that were crowding the posterior fossa and creating that peculiar appearance of the cerebellum. And then you could also confirm the traumatic etiology by identifying the spinal hemorrhage on total spine imaging. So the key points of this presentation are that shaking or impulse loading is a common mechanism for abusive head trauma in young children, and it commonly results in retinal hemorrhage, subdural collections, and parenchymal injury. Correlation with history, clinical findings, and other injuries is key in all suspected abusive head trauma cases. No single injury is pathognomonic for abusive head trauma. And all of these things are put together by a multidisciplinary team, including child abuse pediatricians and other lab workup, et cetera, may be needed to exclude some of the mimics that we talked about. CT and MRI play vital roles and are complementary. An MRI may reveal many additional injuries. Don't forget about these sort of more context-specific injuries that we talk about, the injured bridging veins, parenchymal lacerations, craniocervical junction injury, and spinal subdurals. And then finally, dating of subdural collections and skull fractures should be approached with, and I should say, extreme caution and are generally avoided. It's important to know the things that we can't know for sure. So thank you so much. Thank you to Dr. Goldman-Yast for inviting me, and thank you all so much for your attention. And the next presentation will be by my wonderful colleague here at Vanderbilt, Dr. Alexander Faust, who will be presenting on pediatric neck masses in a month. So thank you so much.
Thank you so much. That was an incredible presentation and a very important topic. And thank you very much for doing it. We have a couple questions that already popped up in the chat. So if anybody else has any other questions, feel free to put them in. So the first one is whether we should about calling it abusive head trauma versus non-accidental trauma.
Yeah,
what we should be calling it. Yeah.
I don't, to be honest with you, I don't really remember why, but I think in the way that I was trained and in most of the reading that I've done, abusive head trauma tends to be the preferred term. Do you have another comment on that, Adam? I don't.
Yeah, no, I think that's kind of the preferred term now, at least from what I've read and learned and been taught. Yeah, that we kind of got to calling it more abusive head trauma to kind of limit the uncertainty of non-accidental. I think non-accidental has a little bit of, you're trying to dance around what it is, but abusive head trauma, I guess, really gets to the point.
Yeah, it's a little broad. Non-accidental trauma is a little vague. So
yeah. And then so another question, how do you know if the spinal subdural is coming from the intracranial cavity migrating down? Or how do you know if the subdural is not coming from the intracranial cavity? How do we know if it's coming from there or not coming from there? Yes.
I feel like based on what I know, I think it's kind of ambiguous. I think if you see intracranial subdurals, it's very likely that that this kind of mechanism that I talked about, where the myodural bridges pull the dura and the arachnoid apart and create a space where that subdural hemorrhage from the intracranial compartment can come down. So that is probably what happens in some scenarios, but I think the fact that it's sometimes seen without intracranial subdurals has led people to also speculate that tearing of those radicular veins is another potential mechanism. So I would think that in any particular case, you can't know with 100% certainty whether it came from the intracranial compartment or whether it was because tearing of the radicular veins or a combination of the two.
Sounds great. Another question, how do you word your impressions to convey strong concern versus uncertainty for abusive head trauma?
So my way of dealing with this, I don't tend to say this is consistent with abusive head trauma or something like that, or this is not consistent with abusive head trauma. I don't go there. I think what's the most helpful to the child abuse pediatricians that I work with is for me to be neutral, and that can use, and I do use buzzwords. So I will say things like bridging vein injury, or I will use that fracture terminology so they and I know that if there's a complex stellate fracture with diastasis that's crossing sutures, so expressing those using the correct terminology can indirectly convey that there's concern for abuse without like putting someone in a corner and saying, I think this is abuse. And then, all the stuff that I've heard about that happens in depositions and courtrooms and stuff based on, our use of language. I find that the best thing to do, and I haven't really gotten in trouble with this, is just trying to be objective in my impression and putting in sort of a concise summary of the findings using, of the salient findings using specific language.
Yeah, makes sense. Yeah, and sometimes I've definitely had cases where the clinicians it's not even on their radar, and you see these findings, and it can be challenging when that's not even on their radar. You're calling them, and this looks like abuse. But
yeah, and
yeah,
that's a good point too, because I didn't mention, and like even in cases where I do that and I don't say it in my impression, I will call them and say I'm worried about abusive head trauma. Like I'll say that to them on the phone. I'll say that to them to their face, but I don't put it in the radiology report because I don't want to put that into a legal record somewhere that is then going to be like a point of contention for someone later.
Yeah, makes sense. Have you ever had to testify in any of these cases? I know I haven't personally. We have a pretty good child abuse team here, which thankfully kind of protects us from that aspects of it. But have you ever had to or have an experience with?
I'm in the same, I'm
Yeah.
going to knock on wood right now because it's
Yeah.
not something I particularly want to do. I haven't had to do that yet, also probably for the same reason, although some of my colleagues here definitely have.
Okay, great. Any other comments, anybody, or questions? And I have another thank you, brilliant and very helpful.
Thank you so much.
I have a question about your so for your protocol, do you routinely do full like a full spine MRI with it, or you do a screening protocol with it?
Yeah, we have a spine MRI protocol that we do that goes along with this, and ours includes a gradient echo sequence, like a gradient echo sag. I don't find that very helpful, honestly. I find the T1s and the T2s in two planes the most helpful, and we have a fluid sensitive, we have a stir sequence also, but in almost all of the cases, we would do a total spine rather than a cervical spine MRI at this point.
Okay, yeah, because so our protocol now, we just kind of do like a screening, just like a sagittal stir, and then if we see something, then we can add on stuff, as opposed to doing like a full spine as a full
I think
spine
that
thing. So I don't
that
know.
can make sense to do. I think if you're able to be there monitoring it live and make sure that someone who knows what's going on is doing that, then I feel like that's a really sensible approach for most things that we do in pediatric neuroradiology.
Sounds good. Anybody else have any other questions or? Excellent, comprehensive talk. Thank you.
Oh, thank you.
Dr. Schechter says.
Thank you. There's some wonderful people on here.
Yeah.
Thank you so much.
Thank you, and thank you. Yeah, thank you so
If
much
anyone
for
has
this.
anything to add.
Yeah. Thank you so much. Thanks for this, and yeah, we'll hope everybody comes back next month for a great talk too. And have a good month, everybody. Thank you so much again for this.
Thank you. Take
Thank you.
care.